All right. Well, first of all, thank you very much for having me here. It's a great pleasure to be in Prague again, despite very elevated challenges. I'm not sure I hope to be able to fly back. I'm pretty sure I would be happy to be quarantined here for the next couple of months, although I'm scared that somebody at some stage will try to find me. I'm also very honored to follow the discussion that has been going on today, in particular the overview that Dr. Canellos did on the development of really the field of medical oncology. Of course, at that times I was not even born. I was born when medical oncology was already a thing, and it was a big thing. But I will tell you that during my 41 years of age, I was able to experience great changes in what we can do now with patients. And to make a single example that actually is outside of the field of immunotherapy that I'm going to discuss for the rest of my talk, if I were born in 1980 and develop a CML, which is chronic myeloid or myelogenous leukemia, that had specific markers, I would have a very high probability of dying. And the same kids that develop the same disease today, they actually have a very large probability of becoming old people and die of something else, probably another cancer or a heart disease, as we have heard before. Those are my disclosure, and Radek also mentioned that we have been collaborating with SOTIO for a long time, but of course I'm not going to discuss anything that relates to these companies today. So we have heard the word cancer many times today, and also George provided some definition, high-level definition of cancer. And indeed, cancer is not a single disease. Actually, cancer is a large panel of diseases going from very aggressive and life-threatening condition, for instance, disseminated pancreatic cancer, down to very benign tumors that we still perceive as cancer, such as basal cell carcinoma. Basal cell carcinoma is so benign that in most cases it's excluded from the cancer statistics, but if you dig in very deeply, you will realize soon that it's the most common form of cancer, and then mostly everybody survives out of that disease. There has been a little discussion about this today. Cancer revolves around the fact that some of the cells of your body are able to, at some stage, lose control and proliferate unrestrained, and they are able first to do it locally, so you will get the real tumor from the Latin word of mass, and then they were going to be able to spread around your body, and those of course are the most dangerous cells because they will colonize other organs. Some of these organs are actually required for survival, so metastatic disease is going to be the major determinant of death in most cancer patients. For a very, very long time, really a long time, cancer was considered as a disease of the cell. It was considered as something that only occurs within a cell that loses control and acquires all of these features that make them dangerous for the individual. And if you go back to the 2000s, so this is from a review article, and then Doug Annan and Bob Weinberg published in Cell, which is a majorly reputed journal from the field, 21 years ago, and you go around this a feature that they found to be common across all types of cancer. They are really all related to the activity of a single cell. And you will see that these cells are able to undergo unrestrained proliferation. They are able to resist cell death, so they are able to survive in a not particularly nice environment, which is the tumor microenvironment. They are able to generate new vessels, so new communication with the organism through which they obtain any sort of sorry about that. To which they obtain support, so nutritional support, they obtain oxygen, but those are also the channels through which the cancer cells become able to invade the rest of the organisms. And then they can go farther away, they can now invade new organs, they can generate new lesions that are those metastases I mentioned about, and this is again something that for a long time was considered as a specific feature of the cells. So what were we able to do about cancer by considering cancer as a cell-intrinsic disease? Of course, it was a very simple approach. We wanted to take cancer away. We wanted really to just get rid of that disease, and we developed three main approaches to that. Surgery, of course, taking away cancer was a good way to remove the disease from the body. Of course, chemotherapy, we have heard about it, and this was also an approach to really target cancer cells, and radiotherapy, more or less the same idea. And the same idea was we are treating cancer as an infectious disease. So we don't really care about the rest of the organisms as long as our approach is not toxic enough. We are gonna just try to kill or remove those infectious agents. Of course, cancer is not an infectious disease, but that was the idea that was underneath the development of the three mainstays of treatment that have permeated medical and radiation oncology for the past century. So those approaches were actually, besides surgery, of course, surgery is somehow simple, but chemotherapy and radiotherapy were really developed according to that approach, which means we are escalating the dose of chemotherapy and radiation therapy as high as possible to be able to treat as much cancer as possible without killing the host. And this is the concept of the maximum tolerated dose, and that it was really both for chemotherapy and radiation therapy. Now the question is, are things really that simple? Is really cancer an infectious disease that we can target by sparing the rest of the organism by this maximum tolerated dose kind of approach? And the answer is actually no. And this is a kind of a complicated slide, but it resumes like 20 years of investigation that were spearheaded by many people actually, but I would want to mention Bob Schreiber here, that they really laid down the foundation of modern immunotherapy and cancer immunology. Basically, this slide tells you that many times a day, a cell from your body loses control and potentially becomes a cancer cell. So if that happens, you would maybe ask, why don't we get 3 types of cancer every week or every day? That is the power of the immune system. So the immune system of your body is able to take care of these newly formed cancer cells in most of the cases. And there is an abundant preclinical and clinical literature out there demonstrating that every day you have several cancer cell precursors that never develop into a tumor. They're just taken care by your own body, by your own immune system. So what happens when then a real tumor is formed? Well, it's relatively simple. These cells that form, and in most cases, are taken care by the immune system. In some cases, very few cases, they have specific alterations that are mutation, as we mentioned before, that render them less visible to the immune system. So at some stage, there is a phase where the immune system is no longer able to take these specific cells under control. These cells start to proliferate slowly. They acquire new alterations. They become ever less visible to the immune system. And at some stage, they completely escape what we call immunosurveillance. Immunosurveillance means your immune system is keeping your disease under control. And this is the only way through which tumors are formed and become clinically manifest. The rest of it is basically an entire process through which there is a pressure from the immune system to select the cells that are much better than others to evade this surveillance. So this was 20 years of work to demonstrate that the immune system can recognize cancer cells, that this is not an infectious disease, that there is something more going on there. So one would ask, this is work from the late 90s, 2000. So I was studying this thing at the university, but the medical oncologists in the 90s were treating patients thinking that chemotherapy and radiation therapy would not engage an immune response, that the immune system had nothing to do with cancer. So why didn't we think about this earlier in history? I mean, we have been studying cancer since the very beginning of the 20th century, even perhaps earlier, but I mean modern medicine. So did it really take us like 100 years to realize that the immune system can do something about cancer? And the answer is absolutely no way. Somebody thought about that in the 19th century. This guy here is William Coley, and he was operating at Memorial Sloan Kettering in the late 19th century. And he was treating cancer patients with a primitive form of immunotherapy. And he actually was able to see some degree of cancer control. Of course, we have obtained a partial literature from what he was doing. The medical and scientific literature was not that developed back then, but nonetheless, 130 years ago, there was a guy doing immunotherapy in New York City, which actually appears to be the very building across the street from where I operate today. So we did think about that a long time ago, but not many people listened. And actually, I would say really few people listened, so much as in 15 years ago, the field of cancer immunotherapy was considered to be a very, very niche field. If you would go to the conference of the SITC, which is the Society for Immunotherapy of Cancer, 20 years ago, it was probably this size, which is, I see in front of me, 25 people. A couple of months ago, a month ago, I was to the SITC meeting, and there was 1,700 scientists and students and attendees, both virtually, of course, given restriction, and in person. So the field has really exploded in the last 20 years, but it's not, the modern immunotherapy really struggled to make it through, even though the bases were there really long ago. So why didn't we think about this before? Because in the 30s to 40s, this Australian guy, Burnett, developed a theory that has been really instrumental for immunologists and for microbiologists, for virologists, which is the theory of the self versus non-self. And it is a very simple theory which tells you that your body, your immune system, is going to be able to react to foreign entities. So the immune system is going to be able to recognize a bacterial infection, a viral infection, a parasitic infection, because they are not you. Your immune system is going to be able to recognize an organ transplant that is not matching your features because it's not you, but unfortunately is not going to be able to recognize anything that is your own, which is why we don't die all of autoimmune diseases, which is actually true. This self-non-self theory has permeated the entire field of biomedical investigation, especially immunologists, microbiologists, and cancer researcher, so that we forgot that there was a guy in the late 1800s in New York City trying to activate the immune system against cancer. Now we know it's possible to do that. We know it's possible because cancer is not really self. Cancer is not really our own healthy cells. Cancer is expressing a lot of markers, a lot of little flags that tell to the immune system there's something going on around here. And the model I showed you before really demonstrate the ability of the immune system to recognize cancer cells. So where are we now? Now we are in a new era. It's called the Era of Cancer Immunotherapy. So much that this was the cover of Science. Probably you've heard about this very important journal for biomedical and for all scientific investigation. And the breakthrough of the year a few years ago was cancer immunotherapy. And 2 people got the Nobel Prize because they really demonstrated that you can they didn't discover the ability of the immune system to control cancer, but they really demonstrated that you can action that therapeutically, that you can action that in the clinic, and you can really get impressive disease control in some patients. We have heard it before, immunotherapy is not for everybody. There is a fraction of patients who respond. It depends on the type of cancer, but also within a specific type of cancer, not everybody responds. But the people who respond, they really experience long-term disease control. So we do see these tailored curves that stay flat, so nobody dies any longer, and they really have massive duration of responses. So what's the difference between immunotherapy and chemotherapy? I mentioned before, chemotherapy are drugs, are agents. They want to kill directly cancer cells or prevent their proliferation. But the idea is really to target the cancer cell because they were developed, all of the chemotherapeutic agents that are conventionally used, they are really now targeting cancer cells because they basically proliferate more than other cells, which also speaks about their toxicity. Those drugs are normally toxic to the cells that proliferate a lot in the body. For instance, the hair follicles. Probably you're all aware of the fact that some chemotherapy is able to, get hair loss as a side effect, or you have the epithelium of the intestines. Also, another very common side effect of chemotherapy is gastrointestinal issues. Immunotherapy does something different. Immunotherapy no longer wants to target cancer cells. So when we shoot this magic bullet, as somebody has called it in the past, we are not targeting the cancer cell anymore. Now we are targeting the immune cells. Now we want to make the immune cells better at doing what they normally do. We want to make the immune cells getting back again on step and getting able to recover this immunosurveillance of the disease that cancer cells were so able to engage in. And guess what? There's a really big amounts of different approaches to immunotherapy. This is actually a slide for a paper of mine dating 2013. I'm sure if I would write the same review article now, I would have to add a few types of treatments. But there's really different approaches. I will tell you in the next couple of slides which are the most successful approaches so far. But these approaches go down from immunostimulatory agents that are delivered systemically, and they want to really push down on the gas pedal. So they want to really make the immune cells stronger and faster to go at the cancer cells. An alternative approach to do that is to release the brakes. A common way that cancer cells have to block the recognition by immune cells is to inhibit their proliferation, to inhibit their activity. And there is a very successful approach to that, which is called immune checkpoint inhibitors, which we're going to talk about in a while. But it goes around the entire circle of using viruses that are engineered to induce an immune response when they kill cancer cells, using therapeutic vaccines. Therapeutic vaccines are not like the COVID vaccine. They don't want to prevent the development of a tumor. They want to re-stimulate the immune system to fight that tumor when the tumor is already on board. And again, there's really an entire plethora of treatments that are now available. Not all of them are clinically available. Some of them are clinically available. They are very successful. Others are in clinical development or preclinical development, which is why getting support to move these treatments forward into clinical testing and eventually into the clinical practice is particularly important. So just as a couple of examples of these successful immunotherapies, this is the example of the immune checkpoint inhibitors, or ICIs. These were developed to really release the brakes that immune cells, specifically a type of immune cells that it is called T cells, receive when they are in the presence of tumor cells. T cells need to be activated, and cancer cells are very able to inhibit that activation, which you see in the left panel. T cells need to kill cancer cells, and cancer cells are very able to protect themselves from the killing. Specifically, they do that by two molecules that are called co-inhibitory receptors, and those are CTLA-4, which is depicted here, and PD-1, which is depicted there. So CTLA-4 inhibits the ability of T cells to get activated against cancer cells, and PD-1 inhibits the ability of T cells to kill cancer cells. These two people, Jim Allison and Onjo, they developed blockers that are antibodies that can impede CTLA-4 and PD-1 from functioning. So now we are in a situation where you can use these antibodies to get a back-there activation of cancer cells and also, of immune cells, T cells, and also to make them much more effective at killing the cancer cells that are present in the body. And this is the approval list for these agents is growing further and further. They started with Epilimumab, which is a CTLA-4 blocking molecule that was approved in 2010. So we're talking about 11 years ago. And then now there's 6 different immune checkpoint inhibitors. Most of them are targeting the other interaction, which is PD-1 and that other molecule there, PD-L1, which is the way through which cancer cells defend themselves. And the indications are moved from melanoma, which was the first one, through different type of cancers, including lung cancer and others. Another successful story for the modern immunotherapy is represented by CAR T cells. Those are a way of taking out the patient immune system. So we take out the patient T cells and we are changing them so that they become able again to target cancer cells. So we genetically modify these cells. So we take them from the patients, we amplify because we need millions and millions of cells. We change their characteristics, and now they have this new molecule, which is called CAR, and the CAR is a way for them to be able to kill cancer cells. And then we give them back to the patients. This is a difficult approach. You need to, there's different steps. It's personalized. You cannot do it with my cells. It has to be with the patient cells that are taken out, changed, and put them back. But we have seen huge overall response rates with these agents in specific indication. For the moment, those indications are limited to hematological tumors. Why? For several reasons, but the simplest explanation that I can give you is hematological tumors, some of them, you don't really care if you kill only cancer cells, because if you kill also the normal cells they come from, and I'm talking about B lymphocytes, you can live and you're going to get replacement therapy for a while, so you're going to be not particularly prone to get infection or anything else as long as you get the other drugs that you need, which is not the case in many other organs. In many other organs, you really need to make a difference between cancer cells and healthy cells. In this case, these drugs are targeting CD19, which is one of these flags I told you before that identify the cells, and CD19 identifies both cancer cells from hematological disorders and normal B cells. So this treatment will take away everything. So what are the major difference between immunotherapy and chemotherapy? What are the advantages and disadvantages here? Okay. First, immunotherapy, since it doesn't target any longer the proliferating cancer cells, it targets the immune system, so there's different side effects. Most often, those are reduced in magnitude. It's not always the case. I've showed you CAR T cells. CAR T cells can generate a very serious side effect, but we are getting better and better at managing these side effects. But in general, aggressive chemotherapy is more toxic. Also, the advantage of immunotherapy is that potentially you generate this immune response. And as you've heard with the COVID vaccine, the immune response is going to stay around, is going to be active in your body probably for the rest of your life. And then it means that if you have a microscopic disease somewhere else that maybe would have translated into a metastasis later in life, this is not going to happen anymore because the immune system is going to take that out, or at least keep it microscopic, which means you're not going to have clinical manifestation of the disease. What are the downside here? Well, immunotherapy, at least until today, is way more expensive. The treatments I showed you, they are considerably more expensive than any form of chemotherapy you can think about. And I mentioned before also that when you see responses to immunotherapy, they are extraordinary. They are long. You get really massive extension in overall survival, but it affects a minority of patients. For instance, in the melanoma setting, you give these immune checkpoint inhibitors I mentioned before, and 20% of the patient, 50 to 20% of the patient will respond. These people will live long and probably happy, but the other 80% of the people did not get any benefit from the approach. So we need ways forward. And where are we going now? We're going multiple directions. First of all is biomarker discovery. We need to know upfront of these 100 patients that get immune checkpoint inhibitors in the melanoma setting. We need to know upfront which are the 20 who are going to respond to treatment. And this is a really strong point, because if we get these 20, we can just treat them. We're going to spare the 80 that will not get benefits. We'll still probably get some side effect. And also, we're going to save the money of A3 treatments, which in the immune checkpoint inhibitors field is not negligible. Next, we are trying to develop combinatorial regimens. This has been alluded to before. So we are not using immune checkpoint inhibitors or other immunotherapy by themselves, after that everything else has failed, which is now, that was the classical development of all therapies. So you test them in patients for which there's no options anymore. Now we are combining them. Now we are using them together with chemotherapy, together with radiotherapy, together with another type of therapy that is called targeted anti-cancer agents. Or we are using them together with each other, because we really want to amplify this overall response rate, so the percentage of people who get the clinical benefit from those agents. And there is work, for instance, combining 2 different immune checkpoint inhibitors in the lung setting increases the response rate above each of the treatment alone. Of course, it comes with increased toxicity. So there is work to do there. We need new preclinical platform, and this is really important, so I'm going to spend a couple of minutes there, even though my clock is running out. We have developed the agents before, as I mentioned, based on the antibiotic-like setting. So we didn't really care that the mice that we were using were immunodeficient or immunocompetent. Actually, they needed to be immunodeficient because we were using human cells. And that is a limitation of what we have today. We never considered, when we were developing chemotherapy, radiotherapy, and target anti-cancer agents, that the immune system would be on board. So now we have drugs that may or may not engage the immune system. We can discuss about it, but we really need to move into models that involve the immune system as early as possible. And also, we need to change the way we design clinical trials, not only for immunotherapy, but also for chemotherapy and radiotherapy. You will see in my last slide, which is the next one, why that is important for radiotherapy and chemotherapy, but believe me, it is. For immunotherapy, as we were focusing on biomarker discovery, we need clinical trials that include very strong immunomonitoring. We want to know what's going on with the immune system of these patients before we give them the drugs, when they receive the drugs, when they stop responding to the drugs, because this is where we can maybe find these biomarkers that will tell us in the future this specific patient will benefit from that specific drug or not. So we're going to be able, again, to spare economical resources and also, more importantly, patients' quality of life, because, again, if you don't get a clinical benefit, there's no point in receiving a drug. This is a fun thing, which is we developed chemotherapy and radiation therapy according to what I told you before, the maximum tolerated dose paradigm, which is increase the dose as much as possible before you kill the patient. And it turns out now that most of the drugs that we use in the clinics that were developed that way, and they were also developed in the immunodeficient animals, so nobody absolutely knew anything about what the immune system was doing there. They only knew that we were not killing the immune system, so we were not killing the patient. It turns out that most of these drugs that were developed empirically in the absence of any immunological consideration, they activate the immune system to some degree, or at least they are compatible with the immune system being activated by the cancer cells. And if you think about the odds of that, if you'd say, okay, maybe 50% should be like that, and 50% should be completely immunosuppressive, because anyway, we don't care about the immune system. And actually, the fact that most of them, if not all of them, are capable to engage the immune system tells you how important is the immune system also for the response to chemotherapy and radiation therapy, even though these agents were developed in a completely different state of mind. And this is also why it's important when we develop clinical trials now to include this immunomonitoring, even when, at least a priori, the mechanism of action of the drugs that we test is not directly related to the immune system. And I think with that, I am done, and I thank you for your attention. Of course, I'm happy to take any questions here.
Okay, thank you. Thank you for a great presentation. So that was also the last presentation. So let me wrap it up everything a little bit. So I think we have heard a lot of good news. So after 50 years, we stay on a track to win a war on cancer. And I think you could see that the SOTIO stays on a track to win the war on cancer. The second good news is that you will be able to play again every presentation. So please follow the website, fightcancer.eu. There will be in a few days, there could be the videos or presentations. So maybe you will see it on the screen. I don't know. Yeah, it's coming. And the last one, I can't tell you the last good news, but I would recommend you that you should follow the websites of SOTIO and social accounts in the next few days, and you will see something very interesting, something big, and maybe you will say, wow. So please follow the SOTIO, and thank you for participation. Thank you all. Thank you for the presentation. Thank you that you were able to travel such a long distances to Robert Cook and Lorenzo Galluzzi. Thank you all. Thank you.